In this video today, we're going to talk to you about carpal tunnel surgery, and not just simple carpal tunnel surgery, but a breakthrough for how to be able to improve pain that you have with carpal tunnel. So, really, what we're going to do is break down the understanding of exactly what is carpal tunnel, how it can affect you, and how you don't need to live with it because you have options. If we haven't met, I'm Dr. Orlando Landrum, and this is a channel that talks about options for pain relief using regenerative medicine, neuromodulation, and other techniques to be able to help punch pain in the face and get back to leading the life that you deserve. So, what we're going to talk about today is a company that's called Sonex that really has been revolutionizing how to be able to treat carpal tunnel. So, for those of you who don't happen to know what carpal tunnel is, we're going to explain that in depth and detail, answer any questions that you might have, and then give you some understanding about how we can be able to potentially treat it. So, when we talk about carpal tunnel, it is something that's located in the wrist and the hand. So, if we're taking a look at this picture, it shows the hand and it shows which areas are normally affected by carpal tunnel. And so the areas that are most likely to be affected by carpal tunnel are going to be things like the ring finger, s- just the half portion, the middle finger, the index finger, and the thumb. So we're going to have some of our guests be able to really explain this in depth and detail. And one of the individuals that I'm both fortunate and blessed to have with us yet once again is Dr. Michael Jackson, who is a physiatrist of phenomenal renown, who is affiliated with Regenix of Iowa and is the main founder and developer of that center, who has dealt with tons of carpal tunnel and has been able to expertly treat patients, give them their life back, and help them. Dr. Jackson,
Hello. Good af-
really appreciate
Oh, thank you again for having me. I truly appreciate the opportunity to come on and talk about good timing on your behalf. Um, I don't think I've ever done 4 median nerves for carpal tunnel in one day. I just finished 2. That's why I'm late. The last 2 I had to rush in here after getting them done. So I have quite a bit of experience with this condition that we're talking about here today.
phenomenal. We're going to have you jump in as well as we're going to have one of the members of the company also be able to join us. And I think that's Ken, who at some point in time will probably go live with his own screen. But what we're going to do is we're going to let you be the star of the show here for a period of time. And we're going to ask you a few questions, not just a couple, dealing with carpal tunnel, particularly since you've already treated 4 patients today. So one of the things that I want to ask you is the following is we were just kind of going through the context of exactly what is carpal tunnel, and can you give us some insight about that?
Absolutely. It's compression of the median nerve specifically. Whenever you have compression of a nerve, and I wish I had a little drawing to share with you guys, but the nerve has a couple of, not a couple, they have humps on them. They're called the nodes of Ranvier. And what happens is the electrical conduction along a nerve doesn't run through the nerve, it jumps on top of the nerve and it jumps over these little nodes. And if you compress 2 of them, they got 2 of them together. If you compress 2 of them, then that'll create a nerve block, and that blocks the conduction of electricity down that nerve. And if you block it at the median or over the carpal tunnel, the median nerve specifically, then it blocks that conduction to the thumb in the first 3.5 digits. So you get numbness and tingling, potentially weakness in those areas, potentially pain in the wrist, pain that may radiate into the hands. You can even have pain that radiates up to the elbow with that condition. But it's basically compression of the median nerve so that the electricity doesn't conduct past it. And so it's about relieving that compression to treat that condition.
Okay, let's see if maybe we might be able to help you out with different models and such that you just kind of described, and then we'll pop up that hand display for carpal tunnel that we took directly from the company's website. 1 second.
Sure. Ah, yes. Schwann cell, nose of Ranvier. Yes, there we go. Beautiful picture. Yes. There we go. That's exactly what I was talking about. How
Yeah.
electricity, the electrical current travels along the outside of that nerve, hopping between those nodes. If you compress two of those nodes, then you'll have a nerve block, and that will create the symptoms I talked about. The compression of that electricity. Now you don't have nervous innervation to the muscles, don't get normal sensory input, and can have pain as a result. So again, treatment is relieving that compression and allowing the electricity to flow smoothly.
Okay. Thank you so much for kind of re-explaining that. Sorry, I was a little bit late with giving you the various different props and preps that you needed for that. So
That's okay.
I think we have one of our representatives from the company who's actually probably maybe multitasking at the same time. Let's see if we can add in real quickly here.
I'm gonna step away real quick. Be right back.
Hey, how's it going, Dr. Landrum?
It's
Yeah,
going
I'm in the
great.
car, so I hope that's okay.
Yeah, we just don't want you to crash anything,
No,
particularly
I
not
pulled
live
I
stream.
pulled into a parking spot.
Phenomenal. All right. Well, we definitely are blessed to have you with us as well. And we certainly want you to jump in when we start talking a little bit about the elements of the company and how you guys got to be able to really produce this revolutionary product and the value that's in place. So hopefully you can be able to kind of jump in and talk to us a little bit about that as well.
Yeah, sure.
I'm not sure if you heard some of what Dr. Jackson was just discussing in regards to carpal tunnel and how it affects people. But if you don't mind, because I know you're doing this on a daily basis, how many people would you say in the United States on average might be really dealing with something like carpal tunnel?
Yeah, the statistics really show about 13 million in the U.S. have some sort of carpal tunnel, and that's from a national perspective. And if you want, I can actually, I can share my screen, and I've got a good slide that can actually show that. If you're okay with that.
Well, running live, we can try it. I think there might be a few people that have some questions here and there, but yeah, if you can try to facilitate that while you're doing that, we may have Dr. Jackson jump back in and talk about some of the risk factors while you're getting that slide deck loaded, if that's okay. That sound
Yeah,
fair?
no, I mean, I've got it. I think I've got it ready to go. Right here. But yeah, I mean, you can talk about it if Dr. Jackson, or tell me if you get this up and running, if that's showing on your screen.
Yep, we're good to go.
Yeah.
Perfect. Yeah. So when you look at it from the unmet need perspective, for every carpal tunnel, there's about 4 patients that actually haven't either gone or been officially diagnosed, that they're maybe seeing their primary care physician, have the symptoms, but have not officially articulated, hey, this is what the issue is, and they've seen somebody like yourself or an orthopedic surgeon. And so, the data really suggests that of that is the 13 million, it's increasing about 2.5 million patients annually. And what's interesting is really only about 600,000 patients are actually getting the procedure. And a lot of it has to do with because of, being, not as keen to wanting to go into an OR setting, from just being scared of surgery, number one. Number two, just the cost of time and the potential of not only from time, but also the cost of the procedure as well.
Okay. So I know, Dr. Jackson, you are pressed for time because you are treating patients and then fitting me in and doing a number of different things all at the same time. And we really appreciate you joining us. Can you
Thank you.
talk to us about some of the risk factors for carpal tunnel? And then how do you go about treating it before we talked about using this type of procedure?
Risk factors for carpal tunnel. Well, the first to jump out for me is if you already have a neuropathy, right? I don't know if you're familiar with double crush syndrome, but sick nerves will potentiate the sickening
Now,
of.
hold on a minute, Dr. Jackson. You've been on our show before. Now, you are getting way too fancy right off the bat. As you know, we are here to talk to patients that this is
Sick
their
nerves.
looking to understand. So break it down for us.
I
Take
am.
this back so that our Michigan patients also can understand and make sure that we got this. All right. So please
Come on.
continue.
It's not the Michigan patients I'm worried about. It's those Indiana folks, but I digress.
Careful.
Anyway, polyneuropathy basically is a sick nerve, right? So you can be a diabetic, an alcoholic, and it'll affect your nerves, the ability of your nerves to conduct that electricity. It'll slow it down. People will have numbness and tingling. Diabetics are probably the most common to have that. So if you have a sick nerve, then you can have what we call double crush syndrome. It's easier for you to develop carpal tunnel. Being overweight, pregnancy. Women will often get pregnant or carpal tunnel while they're pregnant. What other risk factors are there? Work that is repetitive. That's what I see more than anything, are those folks that are using their hands and wrists repetitively, and it builds up the tissue in and around the nerve in the wrist, or people that have not carpal tunnel, but arthritis in their first thumb joint at the base of the thumb there. The bones will sometimes enlarge, and that can cause a narrowing of the carpal tunnel. So those are the primary risk factors that I'm aware of. And you may have seen others, but be aware of others.
Okay, so what are some of the things that you do in your own practice to be able to assess whether someone has carpal tunnel, both on physical examination as well as maybe ultrasound?
Well, yeah, I don't do a lot of ultrasound exam of the carpal tunnel other than to look to see if it is being compressed against the transverse carpal ligament. Oftentimes you can follow that. I will follow the nerve up above and below the carpal tunnel to see if when it's in that one particular space, if it's getting compressed. I know there are some numbers that you can use with respect to how big that carpal or the median nerve is, and that will help you make a diagnosis. I don't feel like that's very reliant, so I don't use that. But usually I start with the history, obviously, and if they have that history of numbness and tingling in those first 4.5 digits, or sorry, 3.5 digits, then that points me in that direction. But the other thing is that it is very, very uncommon when people have exactly the numbness in that reddened area. They will describe numbness there, but they will have numbness when you do the pinprick exam, actually in the ulnar nerve distribution. So then I follow that up with a good physical exam. I'm looking at atrophy of the APB, the abductor pollicis brevis muscle here, which is one of the primary muscles innervated by that median nerve as it comes up the carpal tunnel. I will look for numbness and tingling if I compress the nerve. So if I put my finger here and I compress it for 60 seconds and you get numbness and tingling in that distribution, that's a sign of carpal tunnel. You can do what we call Phelan's test. Hold that for 60 seconds and ignore my tennis elbow wrap here. But if you have numbness and tingling in that distribution after doing this for 60 seconds, then possible. Reverse Phelan's, same thing. Carpal tunnel compression, Phelan's, reverse Phelan's, looking for the atrophy, doing a pinprick assessment, and then the carpal tunnel compression that I do. Those are the things that kind of point me in that direction. And if I'm still concerned, then I may order an electrodiagnostic study or an EMG nerve conduction study. And that's where they will apply electricity to the nerve, either distal or proximal to the carpal tunnel, and see how fast it travels past the carpal tunnel in comparison to the other nerves. You can compare it to the ulnar nerve, which innervates this 1.5 digits on the inside of the hand, or the radial nerve, which innervates the thumb. And so you can also stick a needle into the muscle here, and if it's advanced carpal tunnel, those folks will have these what we call P's and fibs, but it's an abnormal reaction in the muscle. It just kind of reacts on its own when you stick the needle in there. And if you have that, then that's a sign of advanced carpal tunnel. And those are the ones that I won't even attempt to treat with an injection. Those folks, in my opinion, need the carpal tunnel release, especially if they have atrophy and weakness.
Let me ask you a quick question. So you do special type of injections that can be able to help for those that aren't advanced, I believe. Can you
Yes.
tell us a little bit about that?
Yes, that's what I just finished doing. Actually, honestly, just before I walked in, is a median nerve hydrodissection. So we have a nice little mix. You know, that's the beauty of being a part of Regenix, is that these guys have done a ton of research, and we know the mix of growth factor, a little low dose dexamethasone, and a numbing agent that is injected precisely under guidance around the median nerve. So we hydrodissect it out away from the other tissues. And that growth factor will help with reduction in inflammation, also helps heal any of the damaged nerve, those nodes of Ranvier that may be damaged, or so the growth factor can help, again, help heal that. So that's how we do it. It's a very precise injection. And I want to start adding actually carpal tunnel release to that injection.
Okay, so to that point, we're going to add Ken back in to have him talk a little bit about the procedure itself, and we're going to show the procedure after he gives some explanation. But at the end of the day, one of the things that we're really curious about is, how did all of this come about? Can you tell us a little bit about that, Ken?
Yeah, sure. So really, it was two physicians out of the Mayo Clinic that are primary care sports medicine, or PM&R physiatry physicians, that had come to this. And ultimately, this is nothing new. It's ultrasound guidance utilizing our device, the SX1 MicroKnife. And Dr. Jackson said it perfect. You use hydrodissection as the first step, realistically. And right now, what you guys are doing is you're creating a fluid-filled pocket that numbs everything, and that's really the first step of this procedure. It's very similar, which is why you guys get along really well with this. It's a device that's very small that'll go into the wrist, and then there's balloons that open up, creating a safe zone, almost kind of like a highway, so to speak. And then the blade will just, it's a very small blade that cuts the ligament. But our company has been around for a little bit more than 5 years. There's been over 8,000 patients that have had the procedure. The best part about the procedure is patients are back to normal activity in 3 to 6 days. Whereas your normal approach, when it's done in the OR, it can be weeks, if not months. So, the benefit is huge for the patient. Can be an office-based procedure that patients are going home same day and feeling great.
Yeah, that same day piece, I think, is hugely just really desirable for a lot of people, and for them to really be able to say, man, I don't have to go into a hospital for potential treatment. I
Yeah.
think that that's a phenomenal option that many people would love to be able to avail themselves of, particularly for doctors that are like Dr. Jackson, that have the skill to be able to differentiate between, are you appropriate for hydrodissection or are you appropriate for this procedure? I think there's a lot of value. I want to kind of get right to the meat of the matter, because I know people don't want to hear me talk. They want to hear the two of you guys talk, but they probably really want to see this procedure and kind of get some understanding, because we have a few questions that are coming in hot and furious. So I'm going to jump out of here. I'm going to show the procedure, and then maybe you guys can kind of narrate through this a little bit. And I know you're both kind of doing this impromptu, but I think that you guys are more than capable to being able to explain what's going on. So I'm going to jump out for a second. We're going to show the procedure and go from there. Okay.
Yeah. Dr. Jackson, you just interrupt me whenever you want to.
Oh, well, this is your procedure, Ken. You're the guy. You go for it.
Yeah, so what's great is you guys, it's utilizing ultrasound. So you're seeing everything with the ultrasound image. And so here's your critical anatomy that you're looking for: your ulnar artery, your superficial palmar arch, which arches across your palm, the median nerve, which is what compresses underneath the transverse carpal ligament. That's why you're getting that numbing pain, and like you had explained earlier. And so when you play the video, the device is in a very small incision in your wrist. About 95% of the time is closed with just a Band-Aid, no suture. The device goes right underneath that transverse carpal ligament. The balloons will expand, pushes the the critical anatomy, that ulnar artery and median nerve laterally. Mind you, this is all done blunt. When you're ready, this is when the blade comes out, cuts that median, or cuts the transverse carpal ligament, and that's the procedure. It's very efficient. You know, it's 15 minutes at most. Like I said, I mean, patients are driving themselves home afterwards. Close it with a Band-Aid or a steri strip, and yeah, I mean, I use Band-Aid because most patients don't know steri strips.
Yeah. It's just
Most don't. However, I would say we have a question that's coming in, and actually, it's from a phenomenal pain nurse that I know personally, that I used to work with, and who is incredibly well versed. And one of the things that she actually asked is the following. I think you guys can be able to address this. So, does it have to be followed by therapy?
You know, that's up to you guys. I mean, go ahead, Dr. Jackson. I mean, I'm seeing some guys still doing it because that's just their creatures of habits. You know, they want to make sure that the patients do well, but that's a physician choice.
Yeah, and that's a really good question, because I had that arise today as I told the first patient who I did double median nerve hydrodissections on. I normally would not have those patients go through if it's just a really simple case for my hands. However, she's status post-stroke. So to explain that, that means she had a stroke from a motor vehicle accident about 6 months ago, and she still has some residual issues, some residual loss of function in her upper extremities. And so I am going to send her to therapy. The gentleman that I just did, he's pretty much a strict, mild carpal tunnel case. We're just going to let him heal. So it's individualized for every patient. You can't just knee-jerk response and say yes or no. And this is just like knowing who is a good candidate for dissection versus transverse carpal release. Okay. Yeah.
Yeah, I would agree. I would almost parlay it that if patients, and you tell me, you're the doctor, but patients that do get a median nerve hydrodissection, if they end up doing multiple of those, it might be an opportunity to just, you know, take care of the ligament, and, you know, where it kind of really, you know that you're getting a final result, you know, because the ligament, you're taking care of the actual transverse carpal ligament.
That goes back to my original point, and you kind of made it for me, actually, was going in a stepwise manner, right? So if I do one median nerve hydrodissection and they get some benefit, but it returns, or they don't derive benefit, then we're going with carpal tunnel release.
Yep.
We're not going to what failed.
Exactly.
So, gentlemen, I think we have another member of the team, but I'm not sure whether they're going to jump on or not. But I believe we have John that's here, who's looking to see if maybe he might pop in and add a few things. But while we're waiting John to reveal himself, we have another question that is actually up from that same person, and that is Elaine. And she says, does this ever have to be repeated? And I think this is a chip shot that you all can jump in, and I'll get out of there here and let the experts.
I haven't done any cases as of yet. I'm still looking forward to doing my first. So I'll let you guys address that.
Yeah, I mean, so of the 8,000 procedures, there has been one, and that was very early on, that patient actually had to get it done repeated, but it's it's such a small percentage. And the great thing about using ultrasound is you can look at the end of that procedure to ensure that you had a complete release. And when you can do that with a tool and see if it actually goes through the actual ligament and that it's completely cut, the odds of you having to have it repeated are, I mean, less than 0.4%, 0.04%.
Okay. So to that end, can you tell us a little bit about where can patients find out, number one, where do they find a physician who can be able to do this procedure? But number two, more information about this procedure as a whole.
Yeah, so Sonex, sonexhealth.com. That's SNOX health.com. That's one way. And there's videos like you had just shown earlier, talks about the procedure. And then there's actually a portal for patients that can actually look up to the nearest physician near them. And, we're a smaller organization, and we are growing substantially, especially in the COVID world, because so many patients are wanting something done in office and not have to go into an OR. But just at the very top of the screen, you can actually, it'll say we're, physician locator. under patients. So there's physician, patients, and then it should be able to show where the locator is. And to become a part of our locator, a physician has to have done a certain amount of procedures that have seen obviously the great results, and he signs off on being a part of the physician locator. Our website's fairly intuitive. I know you're kind of going on the fly, but it's you can click on patients and it'll drop down and you can say physician finder, or even if you scroll down on the actual patient's page, it's very self-explanatory. And most of the time, patients that have carpal tunnel or have symptoms, because they've already seen you guys and understand some of the lingo, they know what to look for.
Sure, Ken. I'm sure it's operator error. It's probably a lot easier for me to be able to get the procedure than me be able to navigate the website. But that's all right. So, hey, John, we want you to jump in too and make sure that you're part of the party here as well. I guess the thing that I would ask you guys is, so this has really been able to revolutionize some patients' lives. Can you give perspective? Because most people, when they think about carpal tunnel, they think about this only in the context of someone who's a typist or stenographer. But carpal tunnel can be really, wide ranging in nature, as I'm sure Dr. Jackson has had that happen with his 4 patients that he treated today. So can you guys give your own stories of like how it's impacted people for them to be able to get their lives back?
John, you're muted.
There's a couple examples that I'd like to touch on. I have a physician that I work with in Rochester, Minnesota, and actually just the other week, his PA was one of his patients. And the reason that she waited to have this done, she's had carpal tunnel for the last 3 years and waited to have this done until Dr. Kirsch was able to offer this procedure to her because she couldn't afford the time off work. She has young kids, needed to get back to normal activity, didn't want to take time off of work. That's one example. And there was actually a patient that owned his own flooring company who said he hadn't had a good night of sleep in 3 years. And he came in and had bilateral carpal tunnel done the same day. And he was actually back to running his flooring company on that Tuesday. It was done on a Friday, because his story is if he's not working, he's going to lose his business. So those are a couple that I have off the top of my head. And Ken, feel free to share a couple of yours that you've heard as well.
Yeah, I mean, I think it's just getting back to normal activity faster, right? I mean, everybody's scared of any type of procedure where you have to wear a brace longer than you have to or what have you. And I mean, we hear it more and more from patients that they want something quick, right? And I mean, you as physicians, Dr. Jackson and Dr. Landrum, I mean, you guys hear this all the time from patients, right? What's the fastest way to get me back to normal, or what's that? And that's what's so great about this procedure.
Mm-hmm. I would concur. I mean, I am chomping at the bit to have access to this procedure added to my armamentarium, because I've helped a lot of people with mild carpal tunnel, but I've also had a number of those folks that had moderate to severe fail the median nerve hydrodissection and have to go into surgery. And I always feel bad. I mean, I show up to work to help people, and whenever I fail any case, it makes me feel bad. And so I don't have to send those folks away any longer. We have an option for them.
Yeah.
So that's exciting.
So to that end, can you guys talk about insurance coverage for this procedure? Is that something that exists, or what's the mechanism by how someone would be able to acquire this from a financial standpoint?
Yes, so there's a couple different ways. I mean, it depends on the site of service, right? The procedure itself is covered by insurance. A lot of physicians will do a cash pay option, just because for the fact that it is extremely expensive to have carpal tunnel done in the hospital setting. So a lot of patients look to have this done in the office setting because of the cost savings and obviously the return to work. So there's definitely different financial options for all patients to make sure that they have access to this procedure.
Yep, nail on the head.
And can you talk a little bit about the actual device? How did it come about being developed?
So it's kind of a funny story. These guys actually developed, and I'm sure Dr. Landrum and Dr. Jackson, you guys are familiar with Sonex. They were involved with that device as well. So this actually, they were tinkering around in a garage, 6, 7 years ago, coming up with a better way to get patients back to normal activity quicker from carpal tunnel. So it was developed in a garage in southern Minnesota.
I want to add to that. Our company's focus is on ultrasound guided procedures, and this is just one, right? Our major focus is on carpal tunnel release right now. But what's great about our CEO, which is the physician that I had mentioned, Dr. Daryl Barnes, and our chief medical officer, Dr. Jay Smith. We're not a one trick pony. We're looking at other areas of the hand that can make it easy to same concept, simple, easy, return to work, return to functionality sooner. And that's the one thing that's great about this organization.
Ultimately lowering the cost of healthcare by bringing this to the office. I mean, that's what it is. It's a benefit from the outcome side of things for patients, along with an economic component as well.
Yeah.
Okay. So I know that we're kind of running a little bit long on time, and we may be pressing into each one of you guys' busy schedules, because I know you guys are out there, making people better, fixing them up, letting them be able to do the things that they want to be able to do. So I don't want to take up a heck of a whole lot of time from you guys. But I guess the thing that I would say is, when we talk about median nerve hydrodissection, or we're talking about the context of this procedure, if anything, is there something that patients should ask that hasn't been asked already, that they would need to know that I didn't cover?
Wow, good question.
I'd almost challenge. You guys are docs, right? So I almost challenge the norm, and I feel like so many patients go with the splinting route. And I feel like, does that actually work? And I think what I like about what you had said earlier, Dr. Jackson, is, you're able to identify very quickly if you do a hydrodissection, if this is going to work, right? And if it works for a short amount of time, that a complete release is going to for sure work, right? Because they saw some positive for a short amount of time, because that tension was relieved. When I first joined this organization, I was very surprised. I got on Facebook, which I'm not normally on Facebook, and with how many groups there are of tens of thousands of patients that are looking for every snake oil or every type of brace that they can for carpal tunnel. And they are spending hundreds, if not thousands of dollars to try to just get through a couple nights sleeps in a row. Whereas when they come to you, I think being able to have that conversation quick of a hydrodissection or some sort of injection to start, or even knowing their symptoms from a diagnosis perspective and going right to a potential Sonex procedure is what I see the change, versus saying, hey, patient comes in, they have symptoms, try splinting for a couple months, then now you're turning not saying the cost of care, but the time of a patient going to an office, 3, 4, 5 visits before saying, hey, you know what, I should just get a release, or I should just get a hydrodissection.
Yeah. I guess that's a really good point. And it would lead me to say that patients should ask for another option. Dr. Landrum, you've heard me say this multiple times, and medicine should be practiced in a manner within which you exhaust all conservative efforts before moving forth with the more invasive or the last ditch. If you've exhausted all these conservative efforts, you've tried the splints, you've tried the braces, you've had a little bit of hand therapy, maybe a hydrodissection, it's time to find someone who is well-versed in evaluating, diagnosing, and treating, and has all those potential treatment options available for you. That's what I say. You don't go to the guy with a hammer and only has a hammer, because if you don't have a nail, you're not going to have good luck in that clinic. You need to go to someone who has a toolbox and has all kinds of options for you. And this should be a part of that toolbox if you're treating carpal tunnel. So that would be my point. Ask for the other option.
Okay, so, and wrapping this up, I want to show the procedure one more time for those people who joined in late. And again, Ken, John, if you guys don't mind narrating rather, the procedure, I'd greatly appreciate it, so that people can understand exactly the simplicity and really the elegance of what this procedure is able to provide.
Yeah, no problem.
Thank you for the opportunity.
Yeah, thank you.
Ken, you did a great job last time. I'll let you take it again.
I'd run with it. So with ultrasound, you will see all the critical anatomy and what you're kind of staying away from. ulnar artery, superficial palmar arch, which is at the palm of your hand, your median nerve, which is what is compressed against this transverse carpal ligament, right? So the device will be at a small incision at your wrist, and it is a horizontal to the wrist, so it's perpendicular to the wrist crease, very small incision. And go ahead and play the video. The device will go in, and once again, all under ultrasound guidance. You're seeing everything you need. The balloons will then expand. This is a blunt device, so you won't feel anything. The balloons push all the critical anatomy to the side, and then the blade comes from the distal part, cuts the actual ligament, freeing all that, opening up that space. The balloons will then be deflated, and then it's taken out. I feel like when I talk through it, it makes it so simple.
Well, I think it does. I think it gives an explanation to patients really of what it is that we're talking about, how this company has really been able to leverage an option that is minimally invasive, but not only is it minimally invasive, it's safe, and it can be able to get patients back to being able to be functional sooner than not. And I really do appreciate you gentlemen joining me today and really being able to kind of work with our multitude of different schedules and making this all come together, and really being able to leverage this to patients that just didn't know that they had other options, that they thought that they were stuck with just having to deal with splints or just kind of toughing it out or just having to go for open surgery. Making sure that patients understand that they have options to be able to get back to leading their life, punch pain in the face, and really be able to do the things that they want to be able to do.
For sure.
Again,
And
gentlemen,
I'd push it on. You know, like Dr. Jackson, you said earlier, ask when patients are there, ask their options. You know,
Yes.
at the end of the day, a release is a release. But if you can get back to normal activity sooner, you know, why wouldn't you?
Yes.
Okay.
It falls in line with what we do with respect to the orthobiologics, right? The avoidance of the surgical knife or surgical procedure gets you work quicker, less long-term disability. Everybody's happier. So win-win. Love it.
Yeah.
Perfect. And so I know that we know where to find the elements of the procedure. Dr. Jackson, where can patients be able to find you?
I am in Des Moines, Iowa at Regenix Des Moines. The number here is 515-421-4090. That's probably the best way. We also do have a website, Regenix Des Moines. The number to reach out to us is there. Tons of information on the website about the procedures that we perform. I would also like to say that we're also adding not hopefully just this procedure here in the near future, but also some spine procedures. We have some anesthesiologists joining us. So the practice is expanding, and we're extremely excited here at Regenix Des Moines.
Okay. Again, gentlemen, thank you for your time.
Thank
Thank you
you.
for our guests.
Thanks for the time.
Thank you, Dr.
Have a
Landrum.
great day. All right. Take care.
All right, have a good
Bye.
one. Thank you.